Well, it's not a very attractive title, not about nothing. But anyway, did we make any progress with vaccine in other tumor type? I would say yes, and especially in prostate cancer, using T compared to placebo, it improves overall survival. And again, in metastatic melanoma, using ipilimumab compared to placebo, it also improves survival. So when we deal with immunotherapy or targeted vaccine in cancer, we have different kind of treatments, either non-specific stimulation via cytokine, IL-2 and interferon alpha. We have also passive specific immunotherapy with antibodies such as bevacizumab, and we have also active specific immunotherapy, vaccine, and I will go into details, and also immunomodulator working on PD-1, CTLA-4, LAG, or TIM-3. So in order to have a vaccine which could target tumor-associated antigen, first of all, you need to have a criteria of selection for the TTA, lack of pre-existing tolerance, differential expression between tumor and normal tissue, immunogenicity, and a role in tumorigenesis. And in order to present as best as possible this antigen, you need to choose the antigen vector such as peptide, dendritic cells, or viral vectors. So what kind of TAA do we have? We have TAA which are involved in differentiation, mutated antigen. We have antigen which are only expressed in cancer, and we have also antigen overexpressed in tumor. And here I have highlighted in red antigen that we have focused on in different clinical trials in renal cell carcinoma. So now, what are the results about vaccine in kidney cancer? We have, first of all, the vaccine trial, in Phase 3 Adjuvant trial. It's an autologous tumor lysis cell vaccine, which included M0 patient high risk of metastasis. The preparation of the vaccine comes from, the refractory, and 6 intradermal vaccinations were performed at 4 weeks interval compared to no treatment placebo. And here is the 5 and 10 years analysis. As you can see here, looking at PT3, stage 3 disease, it seems to have an advantage in terms of PFS of using the vaccine compared to placebo, but no differences looking at P2 or stage 2 patient. And going to the overall survival data, there is no difference, the p-value is 0.06. So now moving to the VT-SPIN Phase 2 trial, it's a trial which looks at autologous tumor-derived protein peptide complex towards M0 non-metastatic patient high risk of relapse. VT-SPIN was given intradermally once a week for 4 weeks and every 2 weeks thereafter until VT-SPIN depletion. More than 800 patients were enrolled in this study, and the primary endpoint was recurrence-free survival. As you can see here, in the time to treat, no difference, but if you look at the advanced patient population, maybe a better outcome for those patients. But if you look at overall survival, no difference at all. So now moving to metastatic, a sitting TROVAX trial. It's a vaccine towards, the oncofetal 5T4 antigen. It was MVA 5T4 versus placebo combined with cytokine or sunitinib in metastatic setting. Primary endpoint was overall survival. No difference at all, but maybe for some patients who had in baseline, normal baseline hematology, or for patients who had high 5T4 antibody, they could have a benefit from using a vaccine. Now moving to TG4010 Phase 2 trial in metastatic setting. It was a trial which was based on MVA expressing MEK1 and IL-2 alone or combined in progression with cytokine, 37 patients. The primary objective endpoint was objective response rate. No response at all for those patients, but maybe for some patients, around 30 patients had a stable disease lasting for more than 6 months. And the median overall survival was around 19.3. As you can see here, for those patients who had at the beginning a low level of anti-MVA antibody, they had maybe a benefit of using this vaccine. Now moving to the EMA 901 study in Phase 2 metastatic setting. It was EMA 901 is a composition of 10 tumor-associated peptide vaccine. And in this study, patients were randomized to either placebo compared to chemotherapy, cyclophosphamide, in order to decrease the Treg population with this vaccine. And as you can see here about the overall survival, it seemed that to give prior chemotherapy before vaccination could, induce a better outcome in terms of overall survival. Looking at the immune response, for those patients who had an immune response, they do better than those patients who did not have immune response, whatever, placebo or chemotherapy arm. Now, moving to dendritic cells-based tumor vaccination, it was a nice meta-analysis performed by Drobe in 2011. It took into account, 12 clinical trial. It's around, 148 patients who had metastatic kidney cancer. And if you look at meta-analysis based on individual patient data, the objective response rate is around 30%. Clinical benefits, 1 patient out of 2. And those patients who had an objective response rate, it was correlated to cellular immune response and the dose level of dendritic cells that was given to the patient. Now, just to summarize about vaccine trial in adjuvant or metastatic setting, besides the fact that maybe in the RENIALE trial we may have a positive issue in terms of PFS, for the other trial it's quite disappointing. So now maybe this is due to the fact that for those trials we have used in fact either WU or RECIST criteria, and now we should use immune response related criteria, because this is an example for a patient treated with ipilimumab. As you can see here, it seems that after a while we have a progression of the disease, but in fact we have a nice complete disappearance of the tumor, so we need time to let the immunity of the patient to get rid of the cancer cells. Now, what do we have in pockets about vaccine trials in RCC? We have 42 trials, 26 are completed, 8 unknown status, and 8 are ongoing so far. So let me detail those 8 open trials. So we have trial with anti-angiogenic drugs such as bevacizumab or mTOR inhibitor. We have trial with immunomodulator drug, and also we have other strategy using different kind of dendritics treatments. And one is a phase 3 trial, the IMA 901301, and I want to show you into detail about this trial. So it's patients were randomized after first cycle of sunitinib to either chemotherapy plus vaccination and sunitinib for 4 months or sunitinib alone, and the primary endpoint of this study is overall survival. Now, how to improve immune response? First, vaccine trials show that immune responsiveness is predictive of better outcome, and targeting immunosuppressive by myeloid-derived suppressor cells and Treg and T-cell energy is a promising strategy. First of all, this is a study that we performed on sunitinib, which was found out to decrease Treg, and this was correlated to overall survival. As you can see here, after cycle 2 or cycle 3, there is a nice correlation between the decrease of the Treg and the overall survival, and it means that, first of all, Treg decrease could be a predictive factor, and also sunitinib could be associated with vaccination in order to promote the immune system. And this is other study, looking at all the effects of sunitinib, which can decrease the level of PD-1, IL-10, and CTLA-4, reinforcing the fact that maybe this drug could be associated with vaccine. So now, what do we know about immune checkpoint in RCC? We know that the antigen-presenting cells is going to interact with the T-cell population at the TCR level, between interaction between the CD28, leading to promotion of the T-cell population, or you can, at the opposite, have the interaction with PD-1 or CTLA-4, leading to energy of this T-cell population. So this is only a phase 1 study on the CTLA-4 drugs, EP, teclistamab, or this combination, which was too toxic. But as you can see here in kidney cancer, we have some tumor shrinkage, which were very interesting. Now moving to anti-PD-1 drugs, the MDX, it has been looked at in a phase 1/2 study. 18 metastatic RCC at different dose level. And as you can see here, very interesting result in terms either of tumor shrinkage or stabilization for a long period of time. So now moving to my take-home message. First of all, we have limited clinical efficacy of a vaccine in metastatic or adjuvant setting in renal cell carcinoma, but now we know better about better selection about tumor-associated antigen. We have emerging predictive factor. We have to focus on adjuvant disease. We need to take as a primary endpoint overall survival. We need to maybe to combine a vaccine with anti-VEGF therapy or immune control checkpoints such as anti-PD-1. And if you want to perform a vaccine-based clinical trial, you need to first assessment of immune response, evaluation of immunosuppressive pathway, third, use clinical radiological classification, and we are waiting for the phase 3 study, the IMATIX trial. Thank you for your attention.